Hello all, we're next going to talk about localizing lesions in the visual pathway. Starting out, an important concept to cover is how light actually gets into the eye and onto the retina. When light passes through the cornea and lens, it's flipped relative to where it originally came from. So, light coming in from the right side of the visual field goes to the left side of the retina, and light from the left visual field goes to the right side of the retina. This applies to up and down as well. The lower visual field ends up on the upper retina, and upper visual field goes to the lower retina. The majority of our visual field is binocular, with information coming from both eyes. So, we see most of the left visual field with both the left eye and the right eye. However, the most lateral part of the left visual field in our peripheral vision can only be seen by the left eye, and the same goes for the right. Because of how light is flipped as it travels through the cornea and lens, light from the right visual field goes to the nasal retina in the right eye and the temporal retina in the left eye, and vice versa for the left visual field. Something interesting to note is how information from the nasal retina travels differently than the information from the temporal side of the retina. They travel together initially in the optic nerve, but when the optic nerves come to the optic chiasm, the fibers from the nasal retina decussate to the contralateral side, while the fibers from the temporal retina stay on the ipsilateral side. Then, when the visual pathway continues on as the optic tract, everything from the left visual field ends up in the right optic tract, and everything from the right visual field ends up in the left optic tract. So when there is a complete lesion of the optic nerve, there is complete loss of vision in one eye, called monocular vision loss. But when there is a complete lesion of an optic tract, it ends up interrupting vision in one visual hemifield in both eyes. This is called a homonymous hemianopia. Homonymous means that the pattern of visual field loss is the same in both eyes. The loss of vision respects the vertical meridian, a line running down the center of vision, dividing the left visual field from the right visual field. Incomplete lesions to the retina produce localized visual field defects in the single eye's visual field. This is called a scotoma. Lesions of the optic chiasm can produce a distinct pattern of visual loss. When the center of the optic chiasm is injured, it disrupts fibers from the nasal retina on both the left and the right. This results in a condition called bitemporal hemianopia, because the temporal visual fields are lost in both eyes. This results in a loss of peripheral vision, as light from the peripheral vision in both eyes goes to the nasal retina. Causes of bitemporal hemianopia include pituitary adenoma, suprasellar meningioma, and craniopharyngioma. The optic tract feeds into the lateral geniculate nucleus of the thalamus, which serves as a relay station before the primary visual cortex and is involved in initial regulation and reorganization of the visual information. Lesions just to the LGN are rare, but produce unique, interesting patterns. The LGN is supplied by the anterior choroidal artery off of the internal carotid artery, and also the posterior choroidal artery off of the posterior cerebral artery. Because these supply different parts of the LGN, they produce binocular visual loss in patterns known as sectorinopia. In an anterior choroidal artery infarction, the sectorinopia looks like this, with loss of vision in these regions. In posterior choroidal artery infarction, the loss of vision occurs here. A common mnemonic is that the preserved vision in posterior sectorinopia looks like a rear end, corresponding to posterior. You can infer for yourself what the residents say about anterior choroidal artery sectorinopia. After the LGN, white matter fibers travel through the temporal and parietal lobes to the occipital cortex. These are called the optic radiations. Because these fibers fan out into multiple lobes of the brain, lesions here are less likely to disrupt the entire visual hemifield. Instead, we're more likely to see only the temporal fibers or only the parietal fibers become disrupted. We can observe retinotopic arrangements to the optic radiations. Superior fibers running through the parietal lobe carry information from the superior portion of the retina, while the more inferior fibers running through the temporal lobe carry information from the inferior portion of the retina. Now remember how we said that the superior retina is used to detect light in our lower visual field? This means that when there is a lesion of the parietal optic radiations, the patient has loss of vision in the contralateral lower quadrant of the visual field, called an inferior quadrantinopia. And when there's a lesion of the temporal optic radiations, the patient has loss of vision in the contralateral upper quadrants of the visual field, called a superior quadrantinopia. However, if a lesion were to take out all the optic radiations on one side of the brain, we would still see a contralateral homonymous hemianopia. Information goes on to the occipital lobe, where it then begins to undergo more complex processing. It first goes to the primary occipital cortex. Lesions here can be somewhat similar to the ones we've already seen, but they can have a distinct specific difference. Stroke in one of the posterior cerebral arteries can cause an infarct in one hemisphere's primary occipital cortex. Lesions to an entire hemisphere's primary occipital cortex can produce contralateral homonymous hemianopia, except with sparing of the very center of the visual field, known as macular sparing. This is thought to occur for two reasons: because the macular portion of cortex has dual supply from both the posterior cerebral artery and the middle cerebral artery, and also because macular vision may have bilateral representation in both the left and right visual cortex. The primary occipital cortex has a sulcus running through it, called the calcarine fissure. The calcarine fissure divides the primary occipital cortex into superior and inferior portions. Lesions to primary occipital cortex superior to the calcarine fissure produce contralateral inferior quadrantinopia and can have macular sparing. If the lesion occurs inferior to the calcarine fissure, there can be contralateral superior quadrantinopia with macular sparing. After the primary occipital cortex, visual information travels through visual association areas. At the initial association areas, lower-level visual information is represented like spatial orientation and borders. At higher levels of visual association areas, visual information is separated into more specific, advanced components. We divide these higher-level areas into a dorsal where pathway and a ventral what pathway. The dorsal where pathway is involved in visuospatial processing, determining location and the size of objects, and tracking motion. A lesion to the middle temporal V5 area in the dorsal pathway causes echinotopsia, where a patient can perceive stationary objects but cannot perceive motion. Classically, this produces problems with overfilling coffee cups, as the patient cannot perceive when the cup is about to be full. Lesions to the posterior parietal cortex in the dorsal where pathway causes impairments in reaching, grasping, and directing eye movements. In contrast, the ventral what pathway is involved in visual pattern recognition. Lesions to the inferotemporal cortex in the ventral what pathway produce visual agnosias. This includes prosopagnosia, which is the inability to recognize people by their faces, and achromatopsia, which is inability to perceive color. Let's end by briefly talking about trochlear nerve palsies. You probably remember that oculomotor nerve palsies results in the ipsilateral eye pointing down and out. We'll also talk about abducens nerve palsies later in these videos, and how to differentiate them from lesions happening to brainstem structures. But cranial nerve 4 trochlear nerve palsies tend to be a little more subtle. The trochlear nerve innervates the superior oblique muscle. Here's a picture of the superior oblique muscle from a superior angle, which you may remember is shaped like a pulley. Because of how it inserts on the eye, when the superior oblique contracts, it depresses the eye downward, especially when the eye is adducted, meaning when the pupil is angled towards the nose. But the superior oblique also rotates the eye in the coronal plane, rotating the top of the eye closer to the nose, and the bottom of the eye rotates away from the nose. This is called intorsion. When the trochlear nerve is damaged, the ipsilateral eye experiences extorsion from the inferior oblique and the inferior rectus, with very little counteracting intorsion from the superior rectus. Because of this, the eye experiences more extorsion. Since one eye has more extorsion than the other, this disrupts binocular vision and produces diplopia when the patient holds their head straight. Because of this, many patients with trochlear nerve palsies present by tilting their head away from the side with the lesion. This results in normal compensatory rotation of the normal eye, intorting the eye so it is angled the same way as the eye that is on the side of the lesion. When patients with trochlear nerve palsies attempt to adduct the eye on the side of the lesion, such as during an H test, the affected eye is elevated due to loss of depression from the superior oblique.